your election headquarters on TV, radio, and online. Election headquarters, supported by Star Ghana and Infobox. So, the controversy rages. Political parties score points on why we must have 230 or 275 constituencies. Join news, cut to the chase, and put a spotlight on the issues that really matter to you. Constituency Watch, empowering citizens to take charge of our communities from security to purchasing power. Constituency Watch, coming soon on Joy News on Multi TV.
Why are you drifting this argument? We are trying to solve the problem, and you are exacerbating the problem. If you are talking about hypocrisy, you are the hypocrite.
Gentlemen.
First thing that comes into my head is organized irresponsibility on both sides.
The people, with them all on one platform, Newsfile. Together with our audience, we set the agenda for our audience with provocative questions from our seasoned host. Our experts bring on board intelligent and controversial perspectives. Join us on radio and on TV for Newsfile, the pace-setter current affairs program. Newsfile on Multi-TV's Joy News and Joy FM speaks to the big issues and passionately debate the headline stories. Newsfile shows every Saturday at 9 a.m. Viewers can contribute to discussions by phone-ins, Facebook and Twitter, only on Multi-TV.
The election promises, the will and wherewithal to execute. Voters take. We bring it all to you on Manifesto Digest. Here we gauge the wish list versus the reality. How do the promises measure against the records and performance indicators? Manifesto Digest, an election headquarters program, starting this Sunday, 28th October, on Joy News, only on Multi TV, also on radio and online, and supported by Star Ghana. You're tuned in to Joy News, your election headquarters on Multi TV. You're also watching us live on stream.myjoyonline.com. Welcome to the maiden edition of Manifesto Digest, a thought-provoking engagement with political party manifestos. We will gauge the wish list versus the reality tonight and every Sunday same time. My name is Jennifer Jane Asante, and on Manifesto Digest, we will dot the lines, pull off the gloss to test the election promises, as bare as they are, and mark it against the records and performance indicators. You will want to stay with us for this analysis, but before that, remember, you can join us via text code 1760 or post your comments on our Facebook page. Also, WhatsApp us on 0544 334 722. Manifesto Digest is sponsored by Star Ghana. Our radar tonight is on the National Health Insurance Scheme, the NHIS. In 2003, when the scheme was proposed and implemented under the MPP administration, one of the key objectives was to eliminate the existing cash and carry system, which at the time impeded access to quality health care. The Ghana Statistical Service in 2000 estimated that only 44% of those who were ill consulted a medical practitioner, mainly because of the barriers that fee-for-service presented. We now bring you a review of how the scheme has performed over the years and what the parties have said and say what they will do about it. So watch this.
Every Ghanaian contributes to the NHIS through VAT, but up to about 82% remains excluded. According to British NGO Oxfam, the current health system is unfair and inefficient, a claim vehemently refuted by the NHIA in 2011. But the reality is that insurance consumers are not excited with all the problems of affordability, access and quality impeding smooth implementation. Whereas Oxfam said only 18% of Ghanaians are covered under the NHIS, the NHIA pegged it at 48% for active consumers. A Daily Graphic report of March 2011, shortly after the release of Oxfam's report, quotes NHIA boss Sylvester Mensah as saying, NHIS membership as of 2010 stood at 12.2 million, 62% of the population, and active membership stood at 51%. Yet, a World Bank January 2012 report titled Health Financing in Ghana at a Crossroad quotes the NHIS saying active membership in 2010 is 8.16 million, some 34% of the population, a clear contradiction in figures. So really, is the NHIS affordable? Well, NDC in 2008 captured in its manifesto and campaigned on a promise to extend coverage, target registration of women between 15 and 49, especially pregnant women, allow children under 5 to be registered by one parent, register and give NHIS cards to infants at birth registration centres, and involve private healthcare providers to ease the stringent NHIS procedures. There is also the issue of access. The NDC in its 2012 manifesto pens down as achievements of having built 12 district hospitals and 19 health centres for areas with population of over 500. But the picture on the ground suggests the contrary. Has access improved nonetheless? Has cash and carry system ceased with the introduction of the NHIS, or it exists indirectly? Evidence from the field suggests it is still prevalent. The operational challenges confronting the scheme are still visible, and the majority of people out of frustration are forced to pay for services as on a fee-per-service basis. For those who insist on enjoying the full benefit package of the scheme, they are sometimes shortchanged when it comes to efficacious drug administration. How feasible is the talk of the one-time premium? Implementation of this 2008 promise by the NDC has eluded everyone. The party is yet to make good on this promise. In 2010, Dr. Kumbo is quoted as saying the party was going to start implementation, pushing the Techiman NHIS to increase the premium from 14 cities to 18 cities. Nothing happened. Now, Alban Bagbin, who is the third health minister since the NDC assumed office, has said the scheme will start the implementation process in 2013. Interestingly, the party says nothing of a one-time premium in its 2012 manifesto. Can the NDC implement this, or it might just have to shift position on the promise? For their 2012 manifesto, the NDC promises that in the next 4 years, its government will make the NHIS truly national by phasing out the district mutual health insurance schemes, improve efficiency in the provider payment mechanisms, and roll out the capitation nationwide, further strengthening the NHIS in terms of coverage and effectiveness as well as administrative and operational efficiency. Well, the administrative lapses are still there, and the effectiveness and quality of care under the scheme is still questionable. The World Bank January 2012 report warns that the serious structural and operational inefficiencies in the scheme coupled with its expenditure plans, have put it on a bankruptcy trajectory, possibly as early as 2013. The basic benefit package is heavily biased towards curative care. Coordination with Ministry of Health vertical programs is poor, and coverage of 95% of the burden of disease with no cost sharing may not be affordable, the report concludes. When the scheme was introduced, the aim then was to reach 30 to 40% coverage by 2010, rising to 50 to 60 by 2015. According to the NHI's own figures, the scheme is now outperforming the targets set for 2015. This increase in enrollment figures are not matched by infrastructural expansion to address the issue of access, nor logistics and manpower issues to address problems of quality. What about capitation? Is it the way to go in addressing corruption and cost issues under the scheme? However, from explanation on capitation, it is aimed at reducing cost of providing services rather than improving access. Under capitation, providers will be paid depending on the number of patients they provide services to, rather than quality of services they provide. From research conducted by Universal Access Campaign and the comparative analysis made on the matter, it will create a perverse incentive for providers to ration care and reduce quality in the name of efficiency and increasing their profit and further constrain access and quality care. When it comes to expanding coverage, the NDC manifesto states that its government will expand NHI's membership in order to achieve universal health coverage, but falls short of providing alternatives to overcome the challenges of enrolling informal sector workers. The MPP, on the other hand, says it will work with the private sector to add 3 world-class hospitals in the country. On health financing, both the NDC and the MPP manifestos are not clear on how they will tackle the issue of funding. As of now, the scheme still relies on the 2.5% national insurance levy and a 2.5% SNIT contribution. With the World Bank report spelling doom for the scheme in 2013, the parties have failed to take it into account and spell out other funding mechanisms. The bigger problems are fears that the one-time premium will collapse the scheme because operators will stop collecting renewal fees. In the MPP 2012 manifesto, the party promises to extend the free healthcare to children under 18 when the scheme already covers them, if one or both parents are registered with the scheme. Many districts, especially Tamale Metro districts, are already providing free NHIS membership to under 18 children, regardless of whether any of their parents is enrolled. So that manifesto promise does not provide anything significantly new and misses the point on how to achieve universal coverage. The MPP also says it will promote collaboration with private insurance schemes, a promise that does not address the issue of affordability with the NHIS. Again, Nanado has said that the NHIS is collapsing under the NDC and says an MPP government will fix it, but falls short of saying how that will be done. The CPP, in its abridged manifesto, says it will ensure, and I quote, universal and socially funded health system, unquote. But it does not provide specifics on how this will be done in practice. All 3 parties fail to say clearly in their manifestos how they will address the issue of affordability, access, quality, and cost implications, but show a strong political commitment nonetheless to continue the scheme.
So, Has the National Health Insurance Scheme lived up to the bill of improving access to quality healthcare and making it affordable? What has been delivered by the various political parties? And what are their track records while in government? And what exactly are they promising you today? Let's go straight for some answers and meticulously sieve through the rhetoric of the campaign trail for substance. At the end, we'll put these promises to the truth test in the Truthometer and hear the voters' voice on these issues. Remember, you can join us via text on 1760 or post your comments on our Facebook page. Also, WhatsApp us on 0544 334 722. Tonight, my guests are, and I'm taking them from the far right, Professor Agyemang Bedu-Akosa, the CPP Shadow Minister for Health. We also have the MPP Ranking Member of Health, Dr. Richard Anane, and Sylvester Mensah is the NDC NHIS boss. So let's take this from the top, shall we? I'm holding here the NDC 2012 manifesto. It says, advancing the better Ghana agenda, jobs, stability, development. I don't see health. Where does health rank in your top, let's say, 5 priorities?
Well, when you talk of a better Ghana, I mean, Ghana, you're talking about the people of Ghana, a better living condition, better environment for Ghanaians. So health is key, and it's embedded in that, in the title that you see.
Yes, but I asked you to give me a ranking in the top 5.
Ranking?
Is it 1, 2, 3, 4, 5?
Oh, I think it's between 1 and 2.
So 1.5. Okay. Dr. Anane, let's come to you. Where does health rank as far as the MPP is concerned? And what are your own alternatives in terms of healthcare?
Well, based on our previous achievements, we think that the next thing to tackle is education. So now one would look at health as ranking behind education. So if that's what you want in the first place. So first and foremost, education. Second, health. But we also believe that health and education are intertwined, because a healthy, uneducated person can easily access the kind of health service that he or she requires.
Okay, so let's take a look at the CPP. Where does health place on your priority list?
Oh, I think for a country that is suffering from inability to even provide basics for its people, I think health is absolutely tops. I would say that invariably, health comes, health and education are joint first. Second, second is employment, jobs through agriculture primarily. So for us, education and health are conjoint, number 1.
Okay, so for the CPP, it's a tie.
It's a tie, yes, number 1.
All right. You're a health professional, and you were Director General of the Ghana Health Service, so you're probably a big fan of NHIS.
Yes, big fan, yes.
Is it really doing what you expected it to do?
Well, if we start NHIS, I will go back to even the policy formulation that established NHIS. It was as a result of the president of this country saying that in the lifetime of the parliament, there will be no cash and carry. The policy document did not lift that, because you just said that it said that by 2015, you should be achieving, what, 50 to 60%. That does not exclude cash and carry. So cash and carry is still there, and it's still a big issue within the health sector. As far as I'm concerned, health insurance is just a financing mechanism. It is just a way of making sure that as many Ghanaians as would want to access health can do it. Again, one of my major issues that I take is the fact that nobody selects a disease. Apart from diseases that are our own creations, I don't see why some diseases are taken out of the National Health Insurance Scheme. In this country, if you know the number of children that get what we call streptococcal sore throats and skin infections, and end up 14, 15 years later as teenagers with kidney diseases, that we do not include the management of kidney diseases. I don't see how we can do that. We select and choose what suits us, and invariably it's not the diseases that really should hit the Ghanaian population. Again, one of the things that I say is that we are not tackling the burden of disease in this country. And if you're not tackling the burden of disease in this country, then health financing becomes a problem, because it will make sure that NHIS is financially, not sustainable. And I think these are some of the initial comments that I'll make, that we are hitting a system where it might just be financially unsustainable because, number one, we're not tackling the burden of disease. And number two, selectively, we have chosen to omit certain diseases that hit Ghanaians and hit Ghanaians rather badly.
Okay, well, Sly, you're in charge of the NHIS now. Prof is upset that you don't cover everything. Isn't it a standard practice? You don't cover everything?
Well, let me put the discussion in its proper perspective. As we speak today, under 5 mortality has improved, maternal mortality has improved, life expectancy for 2011 was around 62, has improved.
What is it now?
It's 62. We're talking about 2012. I mean, it's only at the end of the year that you could have.
Okay.
Yeah, but certainly would be higher than
so
it was last year.
From what to 62?
It was around 58.
58, and now we're at 62.
It's now 62. Again, when you talk of CHIPS compound implementation, it was around, we had about 800 CHIPS compound in 2008. As at the close of 2011, we had 1,675 CHIPS compound. Again, if you look at OPD attendance by insured clients, as at the close of 2008, it was just above 40%. As we speak today, OPD attendance by insured clients is not less than 82% for public facilities per the Ghana Health Service report. Again, internally generated funds for particularly our public facilities have improved. As we speak today, over 80% of all internally generated funds for our public facilities derive from health insurance subscribers. Again, safe motherhood indicators, that is ANC coverage, has improved, and national scale delivery rate has improved. So if you look at all the indicators, it points to some positive and progressive improvement in the health status of Ghanaians. This is the context within which we are now placing Ghana's health insurance scheme on trial. And let me say that in placing Ghana's health insurance scheme on trial, you are not placing Sylvester Mensah on trial, neither are you placing government on trial. It's a collective effort. It's important to appreciate that the whole idea of a health insurance scheme was mooted way back in 2000 and 2004. It was given a legal backing and the health insurance scheme was established. This country has experienced progressively government after government, irrespective of their political persuasion, deepening the whole idea and concept of delivering quality health care to Ghanaians. It is also important to look at the context within which we are looking at health insurance, having looked at the global picture. Now, cumulative membership in 2008 was around 12.5 million. Cumulative membership as at the close of 2011 was 22.3 million. OPD utilization at the close of 2008 was 9.3 million. At the end of 2011, OPD utilization had risen to 25.4 million. Claims payments have also risen along the same line. This is the context within which we are looking at health insurance. Health insurance has consistently progressed And we are seeing a health insurance scheme today that is healthier than it was before. And we expect that as we carry on year, the health of the scheme will continue to progressively improve. So this is where we find ourselves. Now, coming to the issue of whether the benefit package covers every disease. In any case, there is no social health insurance scheme anywhere in the world that covers 100% disease burden. Ghana's health insurance scheme is considered one of the most generous health insurance schemes, covering about 95% of disease burden in this country. In any case, in determining the benefit package, we always look at a form of a pyramid. And at the base, that is where we have the marginalized, the deprived, the not-haves. And in selecting the package, you would always want to look at the disease that affects majority of the people at the lower end, the poor. And that has been the formula for developing all social health insurance scheme benefit packages. Okay. Perhaps we may engage in discussions to see how to improve or add on to the benefit package. But again, if you look at the NDC manifesto for 2013, the manifesto provides for including prostate cancer, for including the physically challenged, for including mental health, and a few others. We are adding on one after the other, a step at a time. So there is growth, but again, this is a national issue, and it's important that we engage looking at our inflows, our finances, and looking at the packages and having a balance so as to be able to run an efficient and sustainable scheme.
I'm glad you said looking at a balance so that things can be sustainable, because the World Bank is a little worried that we won't be able to keep running things the way they are by, well, next year.
Yeah, I think that the World Bank is not wrong in that conclusion. Sustainability is always defined within the time frame. When the scheme was established, when well, I mean, you cannot use a word like bankrupt for a social protection policy that operates largely on government commitment. Government, unless you want to say government is bankrupt, but you cannot use the word bankrupt for a social protection policy. It's completely not on. Now, before we get there, let me say that sustainability is always measured within a time frame. In 2005, there is an actuarial study that defined the sustainability period of the scheme up to the close of 2009. By implication, if by the close of 2009 we don't receive additional injection of funds, then the scheme, was likely to face some hiccups and cock-ups. What we have done is to extend the sustainability period beyond 2009 to 2012. And when we talk of sustainability period, what comes to mind and what is important to appreciate is that it's like a curve that goes and comes down to touch the x-axis in an asymptotic manner, you understand? So at the end of the sustainability period, it is reasonable to see funds dwindling, because you are getting to the end of the sustainability period. For anyone to make a statement that getting to the close of the sustainability period, you are facing financial challenges, is completely superfluous, because that is what it should be in any case. So that does not add anything at all to the discussion, because getting to the end of the sustainability period, you are expected to have your funds going down until you redefine another sustainability period. And that is where we find ourselves at the moment.
Okay, Dr. Nane, he's talked plenty about sustainability. I just need to ask, what is the MPP's problem with the way the NDC is running the scheme now?
First and foremost, if you even listen to the presentation by the Chief Executive, and you listen to your own, I think you have to congratulate the problem solvers. The NPP is more solution oriented, and whatever you do must be backed by policy. but policies normally are advised by challenges that you identify. And when you identify a challenge, you find a solution to that. In government, you definitely must come out with a policy. And the policy must address the challenges that you identify. In the case of health, one of the major problems that we identify was the question of health finance and access because of inability to maybe get enough money to purchase the health service that you require. So that's how come. And that was the era of the cash and carry. And you remember Prof was talking about cash and carry even still in existence. One would have thought that at this stage we should have been going away and be moving very far away from cash and carry. As we speak now, the number of people who actually are actively participating in the National Health Insurance Scheme is under 10 million.
Under 10 million?
Yes, under 10 million. But I do know that when we decide to capture our children who are supposed to have had free healthcare way back from 2008, and that is about implementation. If we have been able to capture them, that number will have been very large. But as we speak now, the number is under 10 million. Now, if the number is under 10 million, then what implies is that we said the people of this nation cannot access healthcare. And we said the alternative to that problem was about a national health insurance scheme. How come that from 2003, when it was implemented, up to, we are getting to about 10 years. How come that close to a decade, we still are less than 50%?
You've been doing your own research on the side because his figures are considerably higher.
No, they are the same. They are the same. If you look at the figures, you will find that as at 2011, the number of people who actively are participating in health insurance are less than 10 million.
Is that up to 2012?
I said 2011.
11.
Yes.
Okay.
And he cannot contradict that. And why I'm saying so is that why should we, a decade after we started this, and knowing very well the problems that our people have with respect to accessing healthcare, why is that we have not been able to improve upon this and ensure that as many of our people as possible can access healthcare? But we also do appreciate the question of constraints financially, and that's what you're talking about right now. We do know that as many people as come on board, so too do we spend more. We do know that. But then it has to, so to speak, then have to do with the management of the scheme. If you understand that you're going to take on board many, many more people, then you must at the same time find how you are going to manage the little basket that you have been given. And then, if possible, depending on the type of government, you must also know whether there is a need to even get extra more. But the first thing is look at what you have. Is it being managed very well? And if it's so, why is that it's unable to cater for, in this particular case, the less than 50% who are actively partaking in the scheme? We think that the way and manner things have gone the past close to 4 years are not what we would want things to be. We would have wished that by this time, all those who by policy and by law were supposed to have been enjoying the health insurance scheme should be. We also believe that if there is a need to mobilize extra more funds from anywhere, we should. We believe also, I think right now, the word capitation has been given a very negative name. And maybe it's more because of the way it's been implemented. It's not so much the concept, but so much more the way it's been implemented. And we believe that when you are doing anything, you must always take cognizance of the sensibilities of your stakeholders. If you take cognizance of the sensibilities of your stakeholders, and then you prompt them to appreciate also your problems. And there's no reason why we cannot always come to a point where there will be maybe some stability with respect to understanding and to be able to go forward. So as we speak now, we think the management of the entire scheme, because of some of the things that have been done, have created problems. And these problems have created challenges which must be handled. But then again, because we do know that by policy and by law, certain people should be benefiting from it, we must take the bull by the horns and then come on a bipartisan basis, because that's what we have been doing together for a very long time. We agree on so many things. Why don't we? Because when it comes to health, we have always been talking about the fact that let us care for our people. And when we say our people, it's not a CPP or NDC or NPP. It's about the people of Ghana.
I think that it's important to make a little comment on this. When it comes to management of the scheme, I would want to put on record that the management of the scheme in the last 3-4 years has been far, far better than the management of the scheme in the past. Contrary to what Dr. Anani, contrary to what Dr. Anani is saying.
You don't mark yourself.
And I can, let people who are standing somewhere Dr. Anani, in talking about management challenges, was just making a sweeping statement. One would have expected him to talk about issues that this was not done well, this had a challenge, this is a problem, but he just made a sweeping comment. Let me say that we inherited a scheme that was bleeding profusely. Bleeding profusely, and with the introduction of clinical audits, and I have a copy of the clinical audit report here that I can show to you. Usually we just keep this.
You came prepared.
Now, very prepared for this discussion. You know, the clinical audit report reveals the kind of rot in the system with regards to abuses and fraud in the system, to the extent that one teaching hospital alone, Okomfanoche Teaching Hospital, were able to recover through clinical audits. What does clinical audit do? It looks into our historical data, into payments that have been done in the past, looking at diagnosis and treatment to check whether they rhyme and how they manifest in the price that we pay. Over 2 million Ghana cedis was deducted from Okomfanoche Teaching Hospital alone. Through our clinical audits, we have been able to recover nationwide not less than 21 million Ghana cedis. Not 21 million Ghana cedis. Not
That's
only
a lot of money.
Jennifer, I think this program.
Not only that, the claims management process was flawed. We had 145 schemes across the country managing claims, with no clinicians, with very little capacity. What we have done in the process is to set up what we call a consolidated claims processing center that Dr. Anani admires so much. This claims processing center is comparable to any claims processing center anywhere in the world, managing all the big ticket claims from all the teaching hospitals, from all the regional hospitals, from isolated district hospitals across the country, the entire claims in the Volta region, and the results are proving very, very, very positive. I think that not only that, we have also introduced what we call the
this is what you're going to do in the next 4 years, should you get them.
This is what we have done to improve the system. So what I'm saying is that, and beyond that, we also undertook methodology and data validation checks, which revealed that the method used in calculating active membership in the past under Dr. Anani's regime was flawed. Dr. Anani. So we now had to review this so as to get a method consistent with international best practice. And these are all very important and fundamental changes in the scheme. So the scheme you see today is not the scheme you saw in the past. This is an improved scheme in terms of membership.
Improved scheme. So what is the new method of calculating?
The old method of calculating used two variables. One, cumulative membership over the period. So in 2008, the old method required that you aggregate total ID cards issued in 2005 through to 2008, and then you subtract cards that have expired. One, it is difficult to pick on cards that have expired. Two, the cumulative membership includes double counting. People register in one region and move to the other. People die, and they are all added. Now, the new one requires that active membership is calculated on a year-on-year basis and not by going back into the previous years.
So it's not cumulative.
And the variables are one, all new registrations within the year plus all renewals within the year. So you don't have to go back into the previous years aggregating membership and subtracting what does not give accurate numbers. So this has also been rectified, and with this rectification the numbers have been streamlined. If we had used the old membership in calculating active membership, in 2010 active membership would have been 14.1 million. Who will we be deceiving? This is the method that was used in calculating for 2008 and again 2009. So we have refined the system, and I expect Dr. Anani.
What's the number now? Tell us.
Using the old,
going
by the old numbers, would have had
what is the number now?
Using the correct and accurate figure, the figure for 2010 is 1.8. And if you go back to 2008, where we had 9.9, the figure would have been far, far, far less.
So the current figure is?
The current figure is about 8.2.
8.2.
Yes.
All right.
Jennifer, let me say that, you see, this is just a health financing mechanism, and we're assuming that this is the whole health sector. For me, one of the things that I see problematic is the fact that we're not even linking this to the burden of health. If we sit down and talk about OPD attendance and the fact that that is rising is significant for a health financing mechanism, I have an issue with it. One of the things that I talked about is that we're not tackling the burden of disease in this country. If you look at the CPP manifesto, it talks about an integrated system.
We are coming to that.
But it's important we say that, because at the end of the day, you can look at these things and say that, oh, we have the financial sustainability year to 2012, and therefore, of course, the funds will be coming down. But the fact of the matter is that nowhere do we appear to be looking at the burden of disease and analyzing and critically tackling and reducing the burden of disease. If you sit in a country and you're happy that your outpatient numbers are going up, and that is, in a sense, should I say, a variable into the proper management of our scheme, then I have a big problem with it. The fact that we're looking at 22 million people, not mentioning how many people have done 6 episodes, 5 episodes, 4 episodes, and so on and so forth. But I'm saying that here we are as a country. You know, if we talk about health, for me, it's not a health financial mechanism that is top priority. It is ability to reduce the burden of disease through an integrated system looking at the wider social determinants of health. That, for me, is what is important. What we're getting into...
So we will take a break.
No.
Because we need to come back and talk about...
Let me just say that I wish that the NDC had brought somebody else. Because at the moment, it will appear as if Sylvester, as chief executive, is having to defend himself. But in any case, you see, it's a public institution. And a public institution should not be run on party political lines. And I would have expected that the chief executive would not be part of this discussion. If somebody else had come from the NDC and had even met with Sylvester and had gotten this information, it would have been better, you know, than to have the chief executive.
But it's the organizers, because I was invited in my capacity as chief executive.
Yes, because we need to understand what the situation is now.
And I didn't know this was going to assume a political dimension.
Thank you.
I was coming here.
I was told that Omoni Boama was coming.
Well, we are taking a break,
in a sense, was going to be...
So perhaps we want to close the discussion.
No, we're just taking a break, because when we come back, we will get to know what the alternative to the current situation is.
Before you even sign off, if you look at Prof's presentation, talking about the utilization not being any useful indicator, you want to look at a situation where Ghanaians hitherto were not even accessing healthcare because of the catastrophic nature of expenditure.
We will take a look at that when we come back from the break.
The health-taking behaviors have changed as a result of health insurance.
They have changed, and you will tell us more about them when we come back from the break.
Utilization figures that we have.
The problem solved.
Okay, so we are taking our break now. We thank you for joining us on Manifesto Digest. We've been looking at the NHIS. When we come back, our guests will be telling us exactly what their plans for the next 4 years are. You can text us, that's 17 You can paste your comments on our Facebook page. You can also WhatsApp us on 0544 334 722.
Your election headquarters on TV, radio, and online. Election headquarters supported by Star Ghana and Infobox.
Welcome back to Manifesto Digest. Manifesto Digest is sponsored by Star Ghana, and we will be grateful if you join us with your comments via text. That's 1760. Paste it on our Facebook page or WhatsApp us on 0544 334 722. We've been talking about the National Health Insurance Scheme, and Sylvester Mensah needs to make it very clear that he's here as the man in charge of the NHIS, not so much here as a member of the NDC. Does that satisfy you?
No, you invited me as a chief executive to talk about health insurance.
Yes, and that is what we're talking about.
And I thought we were going to stick to health insurance. But the impression I gather now is that you are going beyond health insurance.
No, we're talking about health insurance, and we want to know what plans you have as far as health insurance is concerned for Ghanaians in the next 4 years, should your government still be in power.
Thank you very much. Back to school. Am I?
Yes, you
Great.
are.
Great. Great.
Oh, I'm coming to you next. I have a very special question for you.
Right. Going forward, the health insurance scheme is considering including prostate cancer on its benefit package. The physically challenged would also be covered by the scheme. Mental health cases and patients would be covered by the health insurance scheme. Family planning would also be covered under the benefit package. We are looking towards the introduction of electronic claims submission and claims management, to the effect that providers will now have to submit their claims electronically, which pilot will begin by November this year, where providers will submit their claims electronically and would have these claims vetted or managed electronically. We're also working towards instant issuance of ID cards as a way of addressing the perennial problems of delays in ID card distribution and all that come with it. So going forward, we're going to issue ID cards right on the spot, instantly, so subscribers wouldn't have to go and come. They receive their card instantly. We are working towards a national rollout of capitation as a way of ensuring operational efficiency in the scheme. We are also working towards accelerating coverage of membership and active membership, and a host of others.
A few of the things that you have mentioned, you promised in 2008. Why should we believe that you will do them if you get the mandate in 2012?
Can you mention one thing that I have mentioned here that was mentioned in 2008?
Family planning.
Family planning?
Yes.
Where was it mentioned? I haven't seen that in any document.
Okay. I will find the exact reference for you as we talk.
There is no way you can find that. Family planning was not on the menu. Family planning is now on the menu, and family planning has been part of the new law that has been passed by Parliament, and that is waiting presidential assent.
Okay. So then you're promising...
So all the issues that I've raised here are new issues for the way forward.
There are a few issues that you mentioned in 2008 that we're not hearing of now. You didn't execute those promises, but we're not hearing of them now.
Like?
The one-time premium.
Oh yes, one-time premium. Yeah, one-time premium essentially fits into the global universal health coverage agenda. It provides for easy access to healthcare without the usual annual renewal and a host of others. However, on assumption of office, we realized that it was necessary to prioritize some of these policy implementations. One had to do with ensuring financial efficiency, and two, ensuring that we address the difficulties regarding claims management across the country, and again, establishing as an integral part of the authority clinical audit, and also intensifying our engagements with stakeholders. And we thought that it was important to improve upon these loose ends as a way of looking forward to one-time premium. However, His Excellency the President, John Dramani Mahama, in his recent policy forum, directed the Ministry of Health and the National Health Insurance Authority to engage in stakeholder discussions on the policy or proposed policy of a one-time premium and submit a report at the end of this stakeholder engagement for his consideration.
So where we are now was all set to go out. That was late 2010.
Yeah.
It's 2012 now.
Yeah, that is what I have said. It is being implemented progressively. There are some preconditions. There are some preconditions that should be met in order to superimpose a superstructure on. The foundation has to be strong. We have a weak foundation. We need to inject financial efficiency. We need to ensure that claims management is efficient across the country. We need to ensure that we inject quality and also reduce leakages in the system through clinical audits.
So at the time you made the promise, you didn't know that you needed to do this groundwork first?
Well, I mean, we're not in government. The idea was to address the perennial problems of delays in ID cards and provide some arrangement that will feed into universal health coverage. And we realize that there are a number of issues that need to be addressed, and that we have been addressing progressively.
Okay.
Now we have a number of comments and concerns from stakeholders about the policy of a one-time premium. The president, a listening president, has asked for a stakeholder engagement to determine the future of the one-time premium. So not until we have engaged stakeholders and come out with the collective wisdom and views of stakeholders and submitted to the president, one cannot tell what the situation is, would be. I think that this is where the discussion of one-time premium ends. We haven't conducted a stakeholder engagement. We should conduct before the end of the year.
But when you make a promise, there's a proverb in Akan that says, when a blind man says he's going to throw a stone at you, he's probably standing on one, which tells me that you knew what you needed to do.
Or you could think
you had spoken to Ghanaians, you knew what their concerns were, and you knew what you had to do. So you made a promise, and, well, your term of office is almost over. Have you failed it?
Well, you could feel your leg on the stone, only to realize that it's not a stone. I mean, our expectation on the ground, as far as the health of the scheme was concerned.
So you failed to follow through on your promise?
We have not failed. We are progressively implementing it.
You haven't failed. You're still working through it?
Of course.
As in, you didn't think through the process before you made the promise?
You can't say that, it wasn't thought through. It was thought through. But the objective realities on the ground demand that you prioritize policy implementation to ensure efficiency and success.
You've only recently gone silent on the one-term premium, you know. All throughout your term of office, it's been the one-time premium.
It seems you are not hearing me. I have said exactly what you want to hear from me as my response on the one-time premium. I have indicated to you that there were few challenges that we have had to progressively address. And I've also indicated that as a result of media concerns about the one-time premium, His Excellency the President has directed a stakeholder engagement on one-time premium. Yes. So what else do you want to know about one-time premium?
So as a result of the challenges that you have faced in rolling out this one-time premium, are you telling Ghanaian voters that, yes, we promised we would do this for you, but as a result of these challenges, we have failed to do so?
I'm not in a position to tell Ghanaian voters anything.
All right.
What I am saying is that one-time premium has been a government policy, and this policy implementation has delayed as a result of some challenges on the ground, some preconditions that would have to be addressed before the implementation of the one-time premium. So addressing these challenges is a progressive effort towards implementation. And at this point, I've also indicated that His Excellency the President has directed a stakeholder engagement on the one-time premium. So why don't we wait for the stakeholder engagement? We would invite you to participate in the stakeholder engagement, and when the final report is submitted to the presidency, what follows would uncover before our eyes, and then the way forward will be clearly defined.
Dr. Anane.
Yes, ma'am.
I want your thoughts on this matter. We were told that there was one-time premium, and you said it wouldn't work. And now the NDC says they were facing challenges.
I'm happy you made reference to what I said long ago. And why I did say so was that you don't do things as if you are the only one on earth. And especially when this concept is not something which is new. Health insurance is being practiced all over the world. In the way it started way back in the 1800s in Germany. That's the first country that started it. Under Kaiser Wilhelm I, whose Chancellor Otto von Bismarck, in an attempt to stem the tide of the socialists, the spread of socialist thinking, thought this is one of the measures. In fact, he was the same person who started the pension scheme and so many other interventions. So it is not as if it's a new concept altogether. So many countries have been practicing it. The only country that attempted to do the one time was Australia. And indeed, when they started, they found that it was not workable, and they abandoned it. I drew attention of government to this. I also drew attention to government to the fact that, yes, what you're talking about may not really be a one-time premium, because a one-time premium requires some actuarial study to determine how much in your lifetime you are going to pay. And that will be out of reach of most Ghanaians. So I said, no, I think what you're talking about is the NHS of the UK and so many of these European countries. So why don't you look at yourself much more properly and then come out clearly for people to understand? And one of the things that one were required to have done was the national identification. You know, this was started way back in the 1970s. It was curtailed and then restarted under President Kufuor. And we couldn't finish. And you come to meet it. Finish that one. You have a clear idea about the population and the demographics. And that could help you if you wanted to do the NHS. Because that's going to be financed by the taxes and other things. So
yes,
that's
you mentioned taxes.
Yeah, don't worry. I'm talking about what I told the NDC and why they should not be so quick to finding solutions when they really don't know how to get a solution.
But how is the MPP going to finance, well, keep the NHIS sustainable? You mentioned taxes. Is that what you're looking at?
No. Before I even go for it, our CEO has been saying so many things, especially about the management actions that have been taken. I want to clarify this. That is why he was hired. You are hired to do some job, and you don't mark yourself. You let those who are supposed to do the marking do it for you. Yes. So he was hired to do some job, and he's been doing some. But he should not say that he's been able to do it completely. No, that's by the way. Fine, that's by the way. When you are looking at a system of this nature, and when you do know that it is a big challenge and it's a national matter, you must always be working for a bipartisan approach to a lot of the things. And he knows that we have been cooperating to get solutions to a lot of the challenges that they have been facing. Okay. It's not as if we do not appreciate where we are. We do, but we think that the health of the people should not be pushed into the arena of partisanship.
So you're saying it should be a bipartisan approach,
we have met with them. We have made some suggestions, and I know that it's an election year. They don't want to talk about it. We also will not maybe go a bit too far. But what we do know is that this can be properly managed, and the people of Ghana can get the benefit of it.
Okay.
And if we have any future challenges, we will. Because currently, you are not getting a lot of the documentation that may be available to them. That's why we will not make a promise that we think, yes, we don't fail. We work and make sure we get solutions.
You say you won't make a promise and fail.
But what we can assure you of is what we have said earlier. Because I have told you that we noticed that one of the major problems of Ghana, especially in the health sector, is about access, and especially financial access. And thinking through it, we said this is a solution. But then that solution must have to be managed.
And I need to ask you this because it's been bothering me. Is the current state of the NHIS an indictment on the MPP administration because you implemented it? Why is your policy not sustainable under another administration?
Let me tell you, he claims he's a social democrat. I am not social democrat. I'm coming from the left, from the right of the center. We have different views about how we do and approach things. And I can tell you that coming from where I do and knowing the way we tackle matters, there's no reason why we're going to have problems the way they are having them. Because we see things from different spectacles.
That is true. Prof, of course, I'm sure you see things from another perspective as well.
Maybe to the extreme.
Let me say this, that I think that we've put Sylvester Mensah on a spot here. Because you see, it was an NDC manifesto pledge. It was not the chief executive of NHIA's pledge. And therefore, to expect him to concede something, I think it's a bit, and I just hope that you brought in somebody from NDC to be able to manage that aspect of their program. Again, it's a public servant. At the end of the day, we're just saying that Sylvester Mensah is an NDC man, so that if there is a change of government, he loses his job. But I don't think that is fair. But let me say this, that one-time premium. I had the opportunity to meet the former president, His Excellency, the late Professor Mills.
Okay.
And I went to him to go and discuss one-time premium. And I came to meet Sylvester.
Who is speaking for his party.
Pardon me?
I've been told by my producer that your party says you are speaking on their behalf on this issue.
Okay, fair enough. In that case, then we can take him on the issue. But the fact of the matter is that I came to discuss this issue with him. Because as far as I'm concerned, I thought that, look, even the existing system had a financial sustainability issue. And to go down the route of saying that you were advocating, it did not even say that we're going to virtually marry the two together, but it was a switch to one-time premium. It was certainly not going to work. And I'm glad that finally His Excellency the President has said, let us go for stakeholder consultation. Because at the end of the day, that is what will decide whether we're even going to talk about it ever again, and I hope to God that it ends that discussion. But let me say that, as far as I'm concerned, as a country, what is it that we're doing to decrease the burden of disease? I'll bring that burden of disease to capitation. You see, if you can't get a hold on the burden of disease, and here is a country where environmental sanitation makes disease worse, The water we drink make disease worse. The air we breathe make disease worse. And so on and so forth. The roads we drive on, the vehicles we drive in, all these things that are wider social determinants of health in this country are themselves causes of disease in this country. Now,
it sounds like that is a lot to deal with.
No,
so what is the CPP?
What you need is an integrated system. Look, you go to the Ministry of Health. There must be somebody sitting down, coordinating what is food and agri doing that impacts on health. What is environment, science and technology doing in terms of air pollution that impacts on health? What is water resources doing that impacts on? All these things are not coordinated. Every ministry is doing whatever they think they should do.
So the CPP is going to integrate all of them?
You look at the CPP manifesto, you have it there.
All right.
Look at it. It is there. The second thing is a full rollout of chips. I heard that chips had gone from 800 to 160. Look, you do not get the full benefit of chips until you've rolled it out completely. And it's 6,250 chip zones. When are we going to get there? That, for me, is the solution to the financial sustainability.
And that is what the CPP is promising Ghanaian voters.
No, it is
that they will do.
It is there that will roll out chips. You see, let me tell you something. Because at the end of the day, we're looking at an end game. An end game is the proper health of the people of this country. Let's not sit down and say, health, you tackle it incrementally. We're going from 5% to 10%. In the 10% that you've achieved, many people have died. And they're not giving a second chance at all. So as far as I'm concerned, that is why I say that, sadly, health and education should not be put on a party political platform. Because if you bring in partisanness in health and education, you create problems for the people of Ghana. At the end of the day, those who have been disadvantaged or those who've lacked that opportunity never get a second chance in health, in education, and so many other things. And therefore, as far as we're concerned, we want an end game scenario where the health of the people of this country has improved. And therefore, you've got to look at water. You've got to look at all the things. How can we sit here in a country like ours? Somebody has never drank treated water before. And somebody drinks water from a river where upstream people sadly ease themselves in it. People wash their clothing in it. But that person is also Ghanaian. And therefore, I'm saying that if we can't tackle those things holistically, and that is why health cannot be seen only as medical treatment. Health must be seen in its wider context. And that is what the Convention People's Party has said it would do.
So as far as the NHIS is concerned, the MPP has run it, the NDC is running it. The CPP, what are you going to do about it? Are you keeping it? Are we changing to a new system?
The CPP manifesto talks about universal coverage.
Yes.
We are saying that even in beginning national health insurance, it should have been compulsory. Because, you see, if you take motor insurance, nobody is advised whether you want it or not. Once you've got a motor, what do? You have the motor insurance. Now, if we want the health of the people of this country, and we know that financial access is a problem, then I say that it is incumbent on us to make sure that every Ghanaian adult, if we did that, even the premiums would have been reasonable enough for people to pay. This 2.5% VAT that came in was a salvation. Because otherwise, how else? You see, because it brings in the support of government, it makes it a social program. And I'm saying that the universal coverage for me is fundamental. Let's get everybody sign on to it. Let's make sure that, and I said this, if you say prostate cancer, I will challenge Sylvester. You take prostate cancer, are you going to add radiotherapy? Are you going to add oncology? Are you going to add serial biopsies to it? Are you going to add all the things that one needs to do to ensure that somebody who's got prostate cancer gets properly treated? You see, we take on things, and at the end of the day, probably even the diagnosis of prostate cancer. Up to today, histology is not part of NHIS. So if you say prostate cancer, you are telling me, you just mentioned it by name, but you have not gone into the real specifics of what prostate cancer is.
So does that mean you're going to overhaul the system as it is, so that you have a more comprehensive...
Madam, what I'm saying is that I believe that this is health insurance, is health financing, period. So for me, the most important thing is financial sustainability. How are we going to sustain and make sure that year on year on year, the health insurance is there. I'm saying that you need to look at the burden of disease and tackle the burden of disease head on, which we're not doing in this country. Again, I'm saying that one of the easiest ways to provide health for the majority of the people of this country is through the CHIPS program. The CHIPS program costs far, far less than going to a health center. It costs far, far less than going to a district hospital, a regional hospital, or a teaching hospital. And therefore, if you do that and you create a better gatekeeper system, so that at the end of the day, you can assess these things properly. You know, he talked about fraud, he talked about all these things. If I can get up and walk to Ridge Hospital today and seek health, the cost of seeking health at Ridge Hospital is not the same as going to Carnation Polyclinic. It's not the same. So how do you do all those things that make sure that people do not just get up and because I'm next door to Ridge, I just walk to Ridge? You understand? Right. So these are all fundamental things. And I'm saying that the total you know, you look at health insurance as if it's just health financing. Right. And I just want us to make sure that as a country, we are using that as our major health financing mechanism. And we've got to make sure that this is financially sustainable. Okay,
well, we have sampled the views of some consumers of health here in Ghana. So let's take a look at what they had to say on the issue.
It's probably just an issue of time. I mean, everyone should be enrolled on NHIS.
As a pregnant woman, I have been through a lot because it's not that easy having it. You have it and you go through a whole lot. You are reporting to Kolebu and you are being told to bring a referral letter because you are pregnant. You have the NHIS. And then it got to a time, I realized I reported at the clinic. I know I have my health insurance. And I was told, no, you can't use it anymore. You have to go to another polyclinic. That is not even Kolebu Polyclinic. I have my referral letter that I normally use when I come. I can imagine those who want staff, what they will go through and all that.
But formerly I was using it, but now it's not working. Formerly, when it was initiated, it was working. Now it is not working. At the age of 72, I'm not supposed by the Constitution even to pay money at the hospital. But presently, when I come with the HNIS, most drugs I have to buy with hard-earned money. You see, imagine a pensioner. With my little resources, I have to buy the drugs. When you go, they say it doesn't cover this, it doesn't cover this. It only cover paracetamol, how do you call it, Abombet, and others. You see, in fact, it's a complete failure to we Ghanaians.
One of the challenges is that the price list of the NHI drugs, those lists have to be reviewed periodically. And when I say periodically, I mean if it is every 6 months, that would be very good. You can imagine that almost for a year or two, those price lists have not been reviewed. And so the prices of the drugs, if you come with a prescription and the price of the drug is not commensurate with what is on the HIV list, you are either be forced to give you a price of the drug that is cheaper than what is on the HNIS. That could compromise quality.
You are being admitted into the hospital. We actually don't know whether you are coming to pay cash and carry or you are coming with the NHIS. We ask if you have the NHIS. If you have the NHIS, which means there are certain things of benefit that you not pay for. But without the insurance, you have to pay certain things like the drugs. Even the bed that you sleep on, you have to pay every day. But with the NHIS, it covers the bed, the time you spend in the hospital, some of your drug, most of it covers. It has benefited me. as I'm talking now, NHIS is very good. The perception and the motive they have outside that NHIS is not benefiting them, and then when they come, if you have your mind, that is when you are being looked after. It's not true.
Formerly I was using it, but I stopped using it. Sometimes when I come to the hospital, the drugs, maybe the medication that they give me, they won't give me all the drugs in the hospital, the clinic, or the hospital. Which means I have to buy the other ones at the other clinics. So I thought of it. There's no need for me to waste my time. Rely on the National Health Insurance.
What is happening is, for starters, a lot of the pharmacies or even clinics are not supplying medicines on NHIS regularly because they are not paid. So when you go to most places, there is a queue for NHIS and there's a queue for those who are paying cash. Everybody wants cash, so the cash queue is better. In terms of the quality, they are supposed to supply medicines which are registered by the Food and Drugs Board. So one would assume that they are all the same. But there's a perception that because it's free, it's cheaper, it shouldn't be so if those medicines are properly sourced. However, I also know that most pharmacists, when they are supplying medicines for NHIS, because the NHIS authority has a price, they have to source something cheaper than that price or they'll make no profit. So there is a possibility that all sorts of things will go on. For such medicines for cancer, for instance, I don't know how many of them are supplied by NHIS. But for a fact, you cannot get a branded version because it's too expensive. So you get a cheaper generics. They're supposed to be the same quality. But we know that the evidence is that they are not. Not always. Not in all cases.
My mother has been registered. It's a registered NHIS. I thought it would cover some of the lab, but they didn't cover some of them. And with all this, when I calculated this, why should I waste my time? Because at the end of the day, I have to use money to go and pay. Or they ask me, they give me the reason to go and do the lab outside, not outside the hospital.
Moreover, they do complain of a lot of stress, when they are going for their medications, and they need to have the photocopies of the card and then adding to the necessary prescriptions. And so there are some medications when they write to them, we prescribe when they go to the pharmacy shops for collection. They do tell them it's not available, but when they express the interest that they are capable of paying, then all of a sudden those drugs surface on the shelves of these pharmacy shops which have been accredited by NHIS.
The problem with some drugs is that, drugs come from different sources. And even the handling and all that also is a matter that we all need to look at. It's possible that you could be given a drug, it might not work well, not because the drug is not good, but probably the handling alone was, enough to damage the active ingredients, the storage and all that. So for me, the drug list as it is, and the drugs, if the drugs that are being given to patients are the recommended drugs and the various, safety mechanisms have been put in place by way of storage and all that.
I mean, the NHIS is a very, very important national institution that must be kept, that must be protected, that must be helped. But to do that, you have to do that in a completely non-partisan way. The biggest challenge we have with the NHIS is that it's been too political and too politicized. Secondly, it's got to look at everything. The medicines they supply, the involvement, the buy-in from health professionals, asking questions whether certain conditions like diabetes should not be treated for free. So there are big issues. Fortunately, Ghana has the expertise, the experts to solve those problems. Will the political leaders allow it? I doubt. But the NHIS should be rescued. It's an important national institution. It can transform healthcare in this country.
Welcome back to Manifesto Digest. Manifesto Digest is sponsored by Star Ghana. I have quite a number of messages from our viewers. Zachariah Idi says, Mr. Sylvester should be telling us the number of active clients and not registered. Not all registered can receive services. Women deliver at the scheme centers for difficulty in accessing cards. At the local level, snakebite clients are denied access. Fiasco of one-time scheme. These are the problems that are facing the scheme. Many hospitals and private health centers are not reimbursed and patients are denied. Again, he says, Mr. Sylvester should agree that the NDC has failed on its promise of one-time premium. Even staff of NHIS do not know anything about the one-time premium. All the NDC knows is propaganda. How will they proceed on this when you boycotted the bill in Parliament? I have Gareth Ofori who says, anyone who understands insurance will know that premium is never paid once. And Daniel, billionaire-style Ablakwa, says it is not sustainable. Even in the UK, it is not a one-time premium. I still have quite a bit here. It says, please help us tell the NHIS personnel to educate the public on areas of health covered or not covered in the insurance that they are taking by publishing the information. Thomas says, I support what the Prof says. I also think that Sylvester is the wrong person to talk for NHIS for NDC on this platform. Amwa in Kumasi says, capitation in Ashanti region is killing us. NDC, God is watching you. Thomas is back, and he says Sylvester is still going to talk as an NDC. Thomas, is because his party has asked him to, and that's what he's doing. Reverend Prempe says, thank God for your panelists. Let there be decorum. We are enjoying the discussion. JK Menu in Kaswa says his 2-year-old granddaughter is registered under the NHIS, yet they always buy the drugs on the prescriptions outside the clinic. I have a few more, but because of time I can't go through them. But I would like to hear what you have to say about, well, our voters' voice. Dr. Anane, let's start with you this time.
As I said earlier, it is about a problem or a challenge confronting a nation. A government comes in, identifies the problem, comes out with a policy, makes it mandatory by law, and the people are benefiting. This particular policy, which is now law, and which the people of Ghana are benefiting, are now not seen, or it's now not seen as an MPP owned or an NDC owned. It's seen as a Ghanaian institution. And therefore, everybody is interested in how it moves forward.
Yes.
And that is why you can see what's happening here. And that is why we must be very truthful to the people when we speak to them. And that is why we had said earlier that we do not have to propagandize by talking about one-times that do not exist anywhere. That is why when we say that mothers should benefit for free, they should be given the free health care. That is why we said when children under 18 should be given
Dr.
for free.
Anane, thank you. I'm running out of time.
But we really have not talked about why we're here. We're here to talk about our party and the manifesto of our party and about how we're going to approach health. I want to maybe make one statement about our viewpoint about health. Don't you worry. I have to. My party,
go ahead.
My party, from its past experience, has shown that we see health not as a health sector only problem. And that is why you saw us in education. That is why the president even created an office for a Minister of State in charge of girl-child education. That is why you saw an expansion of the road network.
Yes.
That is why you saw us tackle local government from the point of view of sanitation and other matters. And that we see health not as a health sector only matter.
Yes.
We see health as something that must be tackled from a multi-sectoral standpoint. And there, I'll say that the CPP and the MPP seem to be in sync. Yes.
So, in a few words, could you tell us what the MPP will do with the NHIS when they come in power? That is, if they win the vote.
We will win by all means, because the people have voted by one word.
We need to get reactions from
the people have voted by what they have just sent in. And what the people are saying is that, yes, we have to have confidence in the people who originated and brought it into being. Yes, we must benefit, as they said, by way of mothers benefiting as well as children benefiting. And we, knowing that we had added children and mothers, means that the under 10 million that we are seeing today should be in the region of about 18 million. And if we are looking at 18 million, it means that we, have had to address ourselves to how we're going to fund it. And that is why you found that our presidential candidate, and indeed, at the time when we're talking about children under 18 having to have free health care, we looked at the oil sector and what can be
right. So in the year 2012, you're saying that you're going to move that figure to 18 million. By which year? Could I get a quote on you on that?
Because straight away, we are going to get all the children registered. Because we
straight away?
Yeah, that is our belief.
That is 2013?
And that is what, 2013, yes. Children
2013.
Must be
18 million 2013. We will check the truth of that.
Yes, because all children, especially all school-going children, should initially be, and then all children who are out of school should also be put on board. And then all pregnant mothers will be.
Pregnant mothers as well. So, Mr. Minister, what do you have to say about that? 18 million pregnant women, school-going children.
And so you see that the load will be so
That's
much, and I will have to find a way of financing it. And that's why I said the difference between us and them is because we come from the.
I guess I'm giving him 5 minutes, and you have to do that for everyone to be fair to everyone. Let me say that the health insurance scheme today is experiencing, increasing public confidence as measured by all the relevant indicators of utilization, membership, active membership, and everything. Every single indicator you see today is an improvement of what was seen before.
So in the next 4 years?
And I must also add that from the discussions and the comments that you brought throughout, of course, health insurance anywhere in the world is a challenge. Ghana is making a positive headway. Ghana's health insurance scheme is considered one of the leading health insurance models, not only in Africa, but globally. And we're making quite substantial progress with regards
to... So in the next 4 years, should you remain in power?
In the next 4 years, we're going to see mental health as part of health insurance scheme. We're going to see family planning as part of health insurance scheme. We're going to see the physically challenged also covered under the health insurance scheme. We're going to see prostate cancer under the health insurance scheme.
And can we get a date by which we will see all of this?
Well, we're also going to see an increase in utilization. We're going to see further increase in active membership, and generally we're going to see financial efficiency, and we're also going to see additional inflows that would allow for all these additions into the package
and we will see all of that by when?
You are talking about next term. Is that what you...
Next term.
Yeah,
so
you said next term.
Within the next 4 years?
Within the next 4 years.
All right. Prof. Akosa.
Well, let me say that Ghana is a very fortunate country. We have an infinite resource in what is called white gold, called salt. Since we got black gold, oil, we seem to have abandoned salt. The CPP would make sure that we can produce not 250,000 tons, but at least more than even the 2 million tons that Nigeria needs. We can make so much money out of salt. That is our God-given, resource, so that we can move health, into a sort of a realm. Because without health, you've got nothing. It's fundamental, and that is why we say that we want to move to universal coverage. I wished tomorrow that nobody had to pay anything in any health facility. Cash and carry was supposed to have been abolished. It was not abolished under the term under Kufuor. It has not been abolished under the NDC. And these are some of the things that create problems for people in the health sector. And I just wish that we can make sure that we can get our salt resource managed and done properly, so that we can put even a lot more money into the health sector.
You're
and make
talking
sure
about money and making it universal. Have you costed universal healthcare?
Madam, please. I'm saying that at the moment it is important. You see, cost is important, but you don't start with. You start with an idea. I just wish that you'd have said, "What a brilliant idea!"
Well, it is a brilliant idea, and it is something we would look forward to.
Jumping to cost, I have identified a resource, the only infinite resource that we have in this country. The oil is finite. Everything else is finite. There's one infinite resource that at the moment we produce only 250,000 tons. When we can produce 5 million tons. And I'm saying, let's get that on. And if we get that, that alone, even without tackling oil and gold, can look after the people of this country.
Well, Prof, it was only fair to ask you that question because we did ask them how they were funding what they did.
In this country, we're too quick to talk about. But the fact of the matter is that, is that not what we should be doing? Is that not what politics should be doing for the people of this country? Already, we have all conspired not to give most Ghanaians the opportunity of either of education, of health, and we sit down and all we want to talk about is incremental. I'm saying go exponential.
It's important to find out. I mean, we have asked why certain things haven't been done. We've been told there are challenges. You see, when we're made a promise, we can't just swallow it wholesale. We need to know what's going into it so that we can measure it.
Absolutely. But I'm saying that the whole premise on which National Health Insurance started was on the abolishing of cash and carry in the first term of a parliament.
I have to thank you for that. We have to go for the news.
Supply the correct information.
We haven't achieved that.
No, I'm the one who was asked that question. The question was, when are you going to finish implementing health insurance? And what I did say at the time, that's 2001, was before the end of the term of the administration. But I just want to make it.
I've just been told that we cannot exhaust everything tonight, so we will have a second show.
The law is a bipartisan law. I just wanted you to know that's we have passed a bipartisan law in Parliament, and that law is bipartisan, agrees on mental health, on prostate, on all these things.
So
we'll talk about all these eventually. Yes.
In the second show, I have to apologize to our viewers who sent in text messages and I couldn't go through them. There were so many. But we will add them to the ones we received on our Facebook page, publish them there, and we can continue the discussion. Maybe we will take some of your questions to them directly at the start of the next show. So we will let you know when the second part of the show is coming. But for now, I promised that we would measure the truth against what has been promised. And so now we're going to the truthometer.
Maternal mortality was very high in the 1990s. And it is interesting to note that from 1990 to 1991 to 1990, the maternal mortality rate in the country was in the range of 590 per 100,000 live births. And it dropped to 540 per 100,000 live births around 2000, 2001. To date, estimates of the projections we have indicates that the maternal mortality rate is 340 per 100,000 live births. That shows that there have been improvements from the 1990s figures. But let me indicate that this improvement is far from the target we hope to achieve. At least we're talking about mortality rates of 180 per 100,000 live births, and 340 is still so high. We still have a lot of people dying in the nation's health facilities, and we think that much more still needs to be done.
All right, thank you so very much for coming, but our time is up. Next week we will have another show, and so when we do, we shall revisit some of the issues we have discussed. We shall go into detail. We have news next. Thank you very much, gentlemen, for coming in. And we will be here next week, same time, to take some things apart in manifestos. This has been Manifesto Digest. My name is Jennifer Jane Asante. Good night.